Hello, my name is Patrick Sylvester. I'm from The Ohio State University. The title of my presentation is A Comparison of Tidal Volume Delivered via Adult versus Pediatric Self-Inflating Bags in Adult Manikin Simulation. As a bit of background, the tidal volume delivered by AMBU bags, which I will subsequently refer to as the generic term self-inflating bag, is generally unknown to the operator at the time of their use. This is particularly problematic in an era in which we know one of the best things we can do to limit lung injury is the use of low tidal volume or lung protective ventilation, as pioneered by the ARDSNet studies. If unchecked, excessive tidal volumes may contribute to volume trauma and excessive intrathoracic pressures, which will work against our resuscitation. We're all taught to avoid excessive tidal volumes and are instructed in techniques to mitigate this. However, prior observations had noted that even half of the adult size self-inflating bag might be too large of a tidal volume in the average patient, and that perhaps the volume of a pediatric device might be more closely aligned with the ideal volume. We sought to assess tidal volume delivered using adult and pediatric size self-inflating bags in a simulated environment on an adult-sized Manikin. We recruited a group of nurses and paramedics from affiliated air and ground critical care transport service during one of their training sessions. We obtained a high-fidelity Manikin simulator which was capable of recording tidal volumes delivered on a per-breath basis. We intubated the Manikin with an 8.0 ET tube and instructed our participants to perform rescue ventilation for 2 minutes and randomized them to start with either the adult or pediatric-sized device. After 2 minutes, they were asked to provide rescue ventilation with the other device. Participants were blinded to the data being recorded in real time. Individual breaths were recorded and subsequently used to calculate the tidal volume per kilogram of ideal body weight, in this case assuming a 70 kilogram Manikin, the respiratory rate, and subsequently minute ventilation. We used a dependent t-test to compare these variables between the adult and pediatric devices. Recruitment took place over 3 training sessions and recruited 30 EMS providers. This was a combination of nurses and paramedics, all of which had active ACLS licenses and current employment in this agency. Randomization according to the starting device was balanced between the pediatric and adult devices. This chart shows our findings with regards to the average tidal volume delivered with the adult versus pediatric self-inflating bags. As you can see, the pediatric self-inflating bag was much lower than the adult device, and this was found to be statistically significant. For reference, I would remind us that the upper limit of most conventional starting tidal volume strategies would be around 8 mils per kilo at max, and that's shown here in this dashed line. Respiratory rate was notably higher when using the pediatric self-inflating bag. Again, this was statistically significant. When we consider the recommended respiratory rate with an advanced airway per AHA guidelines, specifically 1 breath every 6 seconds, or 10 breaths per minute, this is shown here. This chart shows the average minute ventilation, which was determined from respiratory rate times average tidal volume. Again, the pediatric bag was notably lower than the adult device, and this was statistically significant. This line shows where the average minute ventilation would be for your usual 70 kilogram individual, and we see that both devices yielded minute ventilations above this goal. As a secondary analysis, we were interested in evaluate the percentage of breaths that landed within the quote ideal tidal volume range of 6 to 8 mils per kilogram. As such, we plotted all breaths recorded for either the adult or pediatric devices as shown here in this chart. Again, the average tidal volume per milliliters per kilogram ideal body weight is identified here. When we give reference lines for where the 6 and 8 mil per kilo boundaries exist, we see that a higher percentage of breaths in the pediatric self-inflating bag were delivered in this range. However, I will note this was not statistically significant. I believe our study shows that the pediatric self-inflating bag delivers tidal volumes that are significantly lower than that of the adult device, notably closer to the recommended tidal volume as suggested by the ARDSNet studies. Pediatric self-inflating bags did yield significantly lower minute ventilation as compared to adult devices. However, these were well above the normal values in the average adult. As far as how this affects clinical care, when I think about how it would be helpful to apply these findings, I first believe that this shows that there needs to be some sort of feedback mechanism, at least during training, but possibly during use, showing us how much of a tidal volume we're delivering during resuscitation. I think based on this study, as well as some previous studies, it would be reasonable to consider using a pediatric-sized bag in an adult patient, perhaps with a PEEP valve, with careful monitoring of end tidal CO2 as a measure of adequate ventilation. Moreover, I think it would be ideal to consider minimizing our time using manual resuscitation and ensure that we're quickly transitioning to travel or standard ventilators as soon as it's feasible during a resuscitation. For future studies, I would be most interested in expanding the study to include additional personnel, including respiratory therapists, nurses, and physicians. I think it'd be interesting to expand this in both an ED and inpatient setting versus just the pre-hospital personnel. Giving participants real-time feedback would be interesting because I think it would help develop muscle memory and consistency in further tidal volume delivery. With regards to the size of the device, additional studies could look at grip strength or hand size to help guide the choice of a particular individual's choice of an adult or pediatric size self-inflating bag. Lastly, I think it would be helpful to measure mean airway pressures using both devices as a surrogate of intrathoracic pressure in the setting of CPR. I would like to thank my mentor, Dr. Eric Adkins, as well as Ryan Sullivan and Dr. Weman, who we worked closely at MedFlight. Lastly, thanks to Jen Frey and David Way, who assisted with our study design and statistical analysis. Thank you very much for your time. If you have any questions, I would be happy to answer them via email.